All right. So welcome everyone. I'm Sanjay Udoshi, my good friend and producer of this town hall and question and answer session. Now week 8 is John Daw. Together we've been doing this for the past 7 weeks in order to provide information to the general public, gather the correct information to provide to you, and answer questions that you may have regarding how to live with in this pandemic and how to process the news and information that you may be coming across. John does this professionally. John is an activist, a political activist as well as a social activist. I'm a physician, internal medicine by training, and my primary career has been involved in data analytics, population health, and genomics. So today we're going to take a bit of a topic-driven approach. John and I have assembled a PowerPoint, and the last couple of weeks we've tried to keep this conversational but structured. So what I'll do is, as I complete a slide, I will ask for any questions that you might have, and hopefully that will structure the conversation for us. Okay, I'm ready to go, John.
All right.
Okay, so what is a risk versus what is a threat? And this is going to be important later on when we talk about hand washing and face masking. Again, this is a topic that we want to cover with you on a weekly basis, at least, because we have a lot of new people joining us on the Zoom, and then a lot of new people are being attracted to the work that we're doing and looking at this after the fact on YouTube or on Facebook. So I want to be able to help you differentiate in your mind what is a risk and what is a threat as you go out into society again, as our communities begin to open back up, their businesses, and we return to somewhat of a more open and less quarantined way of living. So the difference between a risk and a threat, at least the way I'd like you to think about it, is that a risk is somewhat unknown, okay? So when you are in the presence of a number of people and you don't know whether they are sick or not sick or carrying and asymptomatic, that is a scenario like going into a grocery store, a big box store, and there's a high density of people. Many of them are forced to be within 6 feet of each other, or they have to stand in line for a good number of a good amount of time. That really is elevating your risk level to kind of red. Okay, you're in a scenario where you don't know the condition of the environment around you. You don't know how many people are carrying or maybe sick, etc. So that's kind of a red. A yellow is more akin to, you're in an open area and you're walking around a park. It's a busy sunny day, so a lot of people are attracted to that area. It's open air, but you're in the presence of a lot of people that you don't know. So in that event, that is somewhat you should consider as a kind of a yellow area of risk. A green area is you are at home. Okay? You control your environment. You control how clean it is. You control what comes into it. You control who comes into it. You know the status of the people around you as having not been sick or tested or whatever. You have full control over the risk in that environment. That is a green environment. And why am I telling you this? Well, I don't want you sitting at home or in your car or even in your yard with a mask on, because that is an insensible way of dealing with risk. The sensible way of dealing with risk is obviously when you go from green to yellow and come back, then you do the things that you should do to preserve that low level of risk for yourself, which is hand washing, removal of a contaminated mask, taking a shower if you've come back from an area where there were hundreds of people, like a red scenario where you're in an overcrowded big box store, an overcrowded grocery store, and you just kind of feel the crush of humanity around you. then you should come back to your green environment and decontaminate. Okay, so that is risk when you're dealing with the unknown. Okay, so threat. What is threat? Threat is something that's somewhat known, and a lot of people have approached me about, can I go see my doctor now? I have to go and see my dentist. I've got this problem. You know, I need to. I've been nursing a sprained or swollen ankle. Lots of people have approached me saying, you know, I'm really scared to go to the hospital or the ER or the doctor. And to them, I've said, you're right to be scared. Okay, I should say you're right to be very, very cautious about that. And that was the advice given over the last 6 weeks. But now, again, hospitals are opening up to elective procedures. Doctors are beginning to see their patients on a more regular schedule, dentists as well. And so you need to be able to assess, you know, am I going into an environment where I'm at threat? Not risk, threat. Threat is, I want to give you the example. Physician friends of mine have been using the example of having to use a limited amount of personal protective equipment and repeatedly go back into the same room to examine a patient, okay? But, you know, different patients. So every time, you know, a suspected COVID patient is brought in, they're examined in the same space. And over the course of a day, they may see 10 or 15 patients in the same space who are all COVID suspects, right? You know, suspected to be positive for COVID, untested, but coughing and sick. That exam room is a threat to everyone's health, okay? And so that's a threat, not your grocery store or your convenience store, because that's an unknown situation. And we're hoping that most of the people that are sick or have been sick or, you know, understand now that they should not be out in public. That's not completely, you know, reliable, of course. There's going to be a lot of people that are asymptomatically carrying the virus. That's the only way it could have spread this far and wide. But the exam room is the example of a threat. You're going into an ER. You need to be very cautious about that kind of environment and really only let healthcare workers deal with threat, okay? You deal with risk. You deal with assessing your risk on a daily basis. You deal with transitioning from, you know, red to yellow or yellow to green or whatever, and doing the appropriate things to make sure that you don't put yourself in a position to acquire the illness. All right. So that now totally different than risk and threat is who is at risk or what is being at risk. And we were talking about this just before we began. At risk continues to be those over the age of 65, those with long-standing obesity, diabetes, and cardiovascular disease. And to a certain extent, also those with pulmonary disorders like asthma and COPD. But we're learning that cardiovascular risk is actually more risky to have and be around someone that's sick or potentially you know, put yourself at risk than the pulmonary stuff. So what, again, threat level, let healthcare research workers about, you know, biological safety levels and cleaning the hospital environment, cleaning your doctor's offices, because we're trained, we know how to eliminate threats so that each patient you know, is kept safe. And again, I'm taking too long on this slide, but someone wanted me to use the example of if you're a soldier and you're entering a Taliban village, it doesn't matter if there's 20 fighters or if there's 30 or if there's 40. You are under threat, and you know that there's a threat in there. So that's the way you deal with risk and threat. There are way too many variables to assess for the general public to say, oh, you know, this is a threat to my health. That's why we want you to understand the, you know, the red level of risk is going and getting a haircut and sitting in a waiting room with, you know, 6 other people, and you're all 3 feet away from each other. You're putting yourself at high risk. Yellow is going for a walk in a crowded, well, semi-crowded park and, you know, kind of trying to make sure that you are 6 to 12 feet away from people. And green is being, you know, around people that you know that you've known not to be sick for 6 weeks or more, or in your home. Any questions? Next, John. Okay. So again, we're going to go over some basics on what's going to happen in the next 6 weeks. We're going to start with the epidemiological triangle. Right now, we know that COVID is caused by SARS. We're going to, I'm going to discuss in the next couple of slides what we call, breaking the cycle of infection and what we should be focusing on as individuals and also as communities. We know that this is a viral agent. We know that we are its favorite host. We know that the ways that we can get it aren't just from each other talking and being close to each other, but also touching a surface that was coughed on, and the general environment is a risk to us to acquire the agent. Next. All right. So what's an infection reservoir, and why have we been told to stay home for 6 weeks? And why are others complaining that 6 weeks is enough? Let's get back to work. Why is that not a great idea to do in a hasty fashion? This is the cycle of infection, right? So we've identified what causes it. We kind of know what the reservoir is. And the reason a reservoir is important is because people will ask me, all right, you get a cold, and then nobody has a cold for months. And then all of a sudden we get cold season again. And that's strange, right? If cold is transmissible person to person, how can it just reappear months later with very few infections in between? The reason for that is reservoirs. In fact, there's evidence that you can be an asymptomatic carrier of the cold virus, just as we've learned that you're asymptomatically potentially carrying SARS. So people transmit to each other without getting sick, and that keeps the organism viable within community without actually turning on its virulence and becoming part of a season of illness. So this is true with cold, this is true with flu, and we're also afraid that this is true with SARS, CoV-2 or COVID-19. So from the reservoir, it will jump via a path. And the path that we know right now is your fingers, your mouth, your nose, and even to a certain extent, droplets falling into your eyes and infecting your conjunctiva. And so this is the path, right? And so the modes of transmission, which I'll get into next slide, but path of entry, and then who are susceptible, and that basically is everyone. And we'll talk about herd immunity because I know they've gotten a lot of questions about what herd immunity is, and the Sweden model versus New Zealand, and what we're doing as a kind of a midway between complete containment and what Sweden is doing, which is allowing their normal course of disease to spread through their society and develop quote unquote herd immunity. Next slide. Okay, so again, this is just an expansion of it, more pictorial. So you've got germs. The germs live on people, animals, food, soil, water, etc. We know that with SARS, it's mostly people and surfaces. How does it get out? Well, it gets out when sick people cough or talk, or even non-sick people do the same thing. They cough, they talk, they touch stuff, and then the germs then get transmitted via droplet, aerosol, or contact, and they enter the same ways that they left, through the mouth, nose, eyes. And who's susceptible right now? Babies, we haven't seen much of a problem with the very young. We have begun to see problems with an autoimmune style reaction in children. The elderly are highly susceptible, making up nearly 42% of the deaths that we've seen are those above the age of 65. People with weakened immune systems, autoimmune disease, obviously everyone is non-immunized in this situation. Next. All right, so how do we break this, and what are we trying to do now in terms of educate? Like, we didn't really need to educate everybody down to these levels, but it will be useful that to have as many people and around you and your community to understand why we're doing what we're doing and where we're breaking the link, right? So, to tackle the virus itself, we do that by identifying and treating the patients, by attacking the reservoirs. We're trying to decontaminate or disinfect, equipment, instruments, water sources, because as we open up these businesses, there's going to, and the spring and summer unfold, air conditioners are going to come into play. And we know that air conditioners do have quite a bit of, potential to circulate air, and within that air within the room circulating to a great extent, the droplets, aerosol of the virus could potentially contaminate. So obviously that would be someone coughs, it gets drawn into an intake, and then it gets spread through the room by the air conditioning. Making sure that we're masked will reduce the amount of coughing and sneezing and bodily fluid, as well as whatever is on our fingers, trying to minimize that outbound contamination onto surfaces that other people will be using, in public, obviously, at a Starbucks, at a Dunkin' Donuts, at a Chipotle, whatever, there's going to be 50, 100, hundreds of visitors coming in and out, and we want them all to be wearing masks, because that will minimize the amount of contamination, especially in the scenario where we face right now. We don't know the number of people that are asymptomatic carriers of this disease. So we must all be attentive to eliminating the risk of that spread. Then the hand washing comes in, right? The hand washing is important now. Probably a lot of you haven't been really practicing a lot of it at home, because it doesn't make sense in a green environment to be constantly washing your hands. But you will have to learn to do that now. As you exit your house, you want to go out with clean hands, and you want to come back. Before you come back and start touching things in your house, you want to make sure that your hands are clean. So after you've come back from shopping or doing anything outside of your home, the first thing you do, the very first thing you do, wash your hands thoroughly. And that's going to be a very important habit that everybody must do. Otherwise, you will be bringing in contamination. Are we recommending everyone wear gloves in public? No, we are not. We are instead recommending everybody wear masks. There's no evidence that wearing gloves does anything but create more waste. We wear gloves in a clinical environment for various reasons, but and also because the levels of contamination are so high in clinical environments. But for the general public, you are better off building habitual hand washing, right? Making that a general habit of your reentry into your home, and also making a habit of using the mask effectively and not contaminating it. So, Dr. Fauci was on, I think, 60 Minutes this weekend, and they're using a clip of him saying, I don't want everybody walking around with masks, and he's right. If you are 12 to 15 feet away from anyone, or if you're in your yard, or if you're in a park where there's no one else around you, or if you're in your car, don't wear a mask, okay? There's too many reasons for me to go into as to why you shouldn't. You should wear a mask if you know you are going to be in an environment where you are forced to be within 6 feet of people. If you are approaching an area where you know you're going to be within 12 feet of people, you should have the mask on. Under other circumstances, there's no need to wear one. The reason we're doing this, re-education every week, John and I want to stress that the way you get this is not from a cut and blood and, you know, the other mechanisms of getting bacterial infections. This is from oropharyngeal, nasopharyngeal, and tracheal secretions that get, you know, blown out. They're aerosolized, and they land on another person, and that droplet infection causes the transmission of the virus. If you have a mask on, it minimizes, it does not eliminate, it minimizes the risk. If you have the virus in you, it minimizes the risk of you expelling it out into public. Okay, so this is portal of entry, portal of exit. And then obviously we covered people who have, you know, susceptibility, should be extremely cautious and vigilant about this stuff. Next. All right, what's herd immunity? So what happens at, you know, when 30% of the population has been infected and recovers? What happens when we get, is it potentially a scenario where 60% of all Americans within the next 6 to 18 months get the infection? And again, covering this again, 80% of those who get infected will have a mild course of disease. 10% will have moderate to kind of, you know, very bad flu. And then about 10 to 12% will need hospitalization. Of the 10% that get hospitalized, you know, 6.5% will go to the ICU, and you know, about 1.5 to 2.5% will die. So let's talk about the 80% that 80 and 90%, up to 95, I should say, that are survivors over the course of 6 to 18 months. What does that look like? Well, we are beginning to have treatment modalities that work. So I think that, you know, 6 months from now, getting COVID will be a very different scenario than it is today. I mentioned that this last week, that, you know, weeks from now, maybe four weeks from now, the mortality rate from this is going to drop because we've learned to treat it very differently than we did when we began. So we will, you know, start to see a lot more people with herd immunity, right? Sorry, contributing to herd immunity. Now, this is what is not herd immunity, all right? This is allowing the virus to circulate among a general healthy population and then isolating, you know, your elderly and your immune compromised or whoever outside of that population. That does nothing to either protect them long term or generate herd immunity. All you're doing is creating the opportunity for these people in the middle to have to come in contact with those people who cannot live in isolation, you know, for months and months at a time, with never coming across anyone else from society. You're just isolating them like that is just a recipe for not good performance overall when it comes to the key performance indicators of this disease. So the ideal scenario is what's next. All right, so here is 80% immunity. There are 10 people on that screen. 8 of them have either recovered from the disease or been vaccinated. Either way, they will not get sick. If they don't get sick, then they don't transmit the virus to each other, right? And therefore, they won't transmit the virus to those that are most susceptible. This is herd immunity, and this is only achieved with time, patience, vaccination, track and trace, and unfortunately, with a good deal of the population suffering with, the mild to moderate course of the disease. There's got to be someone with herd immunity questions, so I'll pause here. All right, so I'll just cover the last couple of points here. You've been hearing a lot of R naught in the, can everybody hear me okay? I don't know if I've lost people or.
Yep.
Okay, cool. So yeah, so a lot of you have heard about what is R naught as a performance indicator in epidemiology. Um, R naught is the transmissibility of a infectious agent. On the very high end is something like measles, where the R naught is between 12 and 18. So one person can readily infect 12 to 18 other people. That's how highly transmissible and contagious it is. On the lower end, obviously, is something like on the low end is SARS, to be quite honest, or the common cold, or something that doesn't have that has a hard route of infection, that is an infectious agent that's kind of fragile outside of the host. R naught, or transmissibility, is something that occurs naturally. We're seeing that the R naught of COVID-19 is between 2 and 3. That means that, over a course of 6 weeks, there is exponential growth. And the doubling rate is extremely difficult to manage. Higher the R naught, the more transmissible, the shorter the doubling time, etc. Now, RE is what we use as R effective instead of R naught. It's what happens when we implement non-pharmaceutical interventions. And non-pharmaceutical interventions are physical distancing, usage of masks, insistence on hand washing, reduction in crowding, insisting that we don't hold large community events like sporting events and things like that. These things are short term. Depends on your tolerance for the definition of short term being months. And eventually what we are able to do is bring that R naught down to less than 1. That means that one person will eventually infect less than one other person at scale. So, and the reason we do that is because we keep people away from each other for a long enough time that the latency and the incubation period and the reservoir of infection out in the community is reduced significantly, and therefore the risk level is reduced. Okay, now questions.
Yeah, I have a question, Sanjay.
Yes.
Say, as an example, if you lived in a backward state like Texas.
Okay.
I picked that one for no specific reason.
Yes, of course. Yeah.
And they're rushing to open up everything, you know, and they've already said that there's no consequence for violating any of the protective orders. Once they're open up, does that change the R naught number, or is that set in stone? I mean, once you get more people out.
So it changes not the R naught, because the R naught is innate to the infectious agent. Okay. So we're still dealing with the same infectious agent, and I'll get to why it changes a little bit over time. But R naught stays pretty static. And when I say measles is 12 to 18, there's some strains of measles that were extremely aggressive and extremely virulent and extremely transmissible. And then on the low end of 12, 12 is still ridiculously high, right? So when I say R naught of 2 to 3, that means one person can infect 2 people, or they could have a strain that's aggressive enough to infect 3 people, right? So that will stay pretty static. We're not going to wake up one day and the R naught has jumped to 6. That's very, very, very unknown, unseen. So I would say not impossible, but so rare that we haven't encountered an infectious agent like that. What does change immediately is R effective. So if you remove these non-pharmaceutical interventions, then you have an immediate effect on the transmissibility. Let's call it transmissibility quotient of the virus. Then you have the reservoirs refilling, right? You start to refill the reservoir with infectious agent because you have people back out into the community doing and whatever they want. especially if they're not obeying mask wearing, especially if they're not, using the red, yellow, green to assess and deal with risk. If they just feel like they're as safe out in public as they are at home, like we used to feel, then your R effective goes back up.
Yeah, I never understood how Texas is going out whole hog. They're saying they're at 25%, and that's a wink. You know what I mean?
Yeah.
It's sort of like everything open up, and we're going to pretend we're at 25%. And already our numbers are going up.
Now, when you say you're at 25%, what is that? 25% what?
They say their opening business is up to 25%, and then they're going to stage it to 50%, and then they're going to stage it. And I've heard people saying that they've gone by restaurants where the patios were full. No one had a mask on, and
I've heard this in Florida. Yeah.
So that's why I wondered if that affected the R naught at all, especially you have such a huge base now to work off of.
Yeah. Now, let's say you've got it below 2, right? Let's say you've got enough people separated apart for enough amount of time that reservoir has reduced, the risk level in the community has reduced. You immediately open stuff up, even at 25%, your R effective is going to go back up. And then what happened in Georgia was they said, we're going to open up May 1st or May 8th or whatever. And tons of people from the neighboring states came to Georgia, 62,000. Because they wanted, they just needed to get to a bar or they needed to get to a restaurant. And so they drove. And when you have 62,000 people from outside of Georgia entering whatever different communities where they're doing business now and are open, come on, immediately that you've done all this work for 6 weeks to bring the R naught down from 3 or 2 to less than 2, and you're trying to get it to below 1, but with 62,000 people rushing in to take advantage of reopening, that's going to shoot right back up to between 2 and 3.
Well,
you just lost all of that work.
Well, everything that all these states that are reopening, and the playbook was supposed to be based on increased testing, and that's gone. That was a pipe dream. That was just a thing they threw out there as an excuse to start opening stuff up. There is not the level of testing being done. Like, give you an example, like Texas, where they already announced that they were shutting down some of the federally funded sites for testing. And they're going to leave it on the counties because, the state won't pick that up. But the counties now have to scramble and try and find some way to continue testing people.
Yeah, exactly. So later on, we'll be talking about why testing is important. And then Sanjay's 5-point strategy to get back America the way we had it. Because it's a combination of all these things that you just mentioned. But, if we all work together, we can suppress the R effective to a point where R effective will be different. It will be much higher. It will continue to be high in urban areas. But in Wilkes-Barre, Scranton, where we live in a suburban area that borders rural, that R effective could be really low. But it takes the community to deal with this, and like I just gave you the Georgia example. Okay, you can open up 25% of the businesses, but if all 25% of the businesses operate at capacity, you know what I mean? Do you see what I mean, Terry?
Yeah, it flushes the
progress down the
yeah, everything is out the. I feel like down here, Texas, everything is out the window now. It's the rush is to see how fast you can get open. And since no one there's no oversight to it, the 25% was a joke. No one opened up to just 25%. So it makes you think that on top of that, any social distancing, any of that is right out the window.
Yeah. Yeah, exactly. So, all right, so let's keep going, and then I'll get to the. All right, so, all right, I'm going to quickly cover this. This is technical, but I'm going to quickly cover this because you're going to start hearing about drugs now, and I want you to have a framework to think about how drugs work, so it'll make sense. If drugs don't fit into a certain category, or they're not, modeled after this new way of thinking about how they're effective, then you can take it with a grain of salt. So, for example, what is a pathway? You can see on the right here that the virus attaches to your cell. It goes through a process of fusing with the cell membrane of your cell. It releases its genetic material, and then in the green boxes, I've indicated which are the drugs that act at which step of the viral life cycle, and why we're investigating certain drugs at these critical steps. So the virus enters, it releases its genetic material. The normal machinery of your cell, the cells inside of your lungs, the epithelium, they start reading that viral DNA, and they start producing proteins as if it was your own genetic material. And then, various mechanisms happen, and then it goes through a replication cycle where those proteins start producing more virus. Okay, so you'll see a name in the green box near the bottom here that says Gilead remdesivir. So remdesivir is the drug that has been fast-tracked and FDA approved by the administration recently, and that drug acts where you're seeing a point there where the virus is trying to create more copies of itself. All right. So on the left, I'm showing you the steps. So what's the pathway? The viral attachment, then the translation of its genetic material, then its replication step, and then the propagation step is daughter viruses then get spilled out, and they go and infect all the rest of the cells that they can find in your body that have, the ability to bind the viral proteins. So again, attachment, translation, replication, and propagation. These are the 4 basic steps in the pathway. There's a lot of very complicated cellular machinery that the virus hijacks. And when it hijacks it, we're trying to stop it at various steps. Now, this diagram is from the early days. Early days, can you believe early days was February? So early days of this infection, where we were investigating whether the paper from France, where they did a experiment on 26 people with hydroxychloroquine, which is the anti-malarial, whether that would work on the viral fusion step. We've discovered that it doesn't. And then, we have to keep testing. We have to keep testing all of these drugs where we believe they may have efficacy at the stages at which the virus is trying to hijack your cells. And if these do, in fact, have that desired effect in stopping that step at that place, then what concentration do we have to give it to you at? For how long until we really, affect the virus in a positive way that reduces the course of disease or reduces the severity of disease? So you can see the next one that's under investigation is remdesivir. I have more on a slide I'll show you later that are even better candidates that are more recently found to be effective in one of these 4 steps. Next. Okay, so droplets and fomites. Remember, we talked about this. I probably misplaced this. This slide should have come up earlier, but we covered this a couple of weeks ago. Droplet-borne infection is 2 people, you're standing across from each other, they're talking, inevitably that, aerosolizes the saliva and whatever from inside the mouth and throat of the person who's talking. That goes out into the air. The small droplets rise, the heavier droplets fall to the ground. Let's say that they're having this conversation over a table. So you can see the thing in the middle, the fomite route. Those droplets are going to fall to the surface. They're going to stay there. Certain research shows that depending on the droplet size, the temperature, and other factors, that surface can, hold a infective virus for 3 hours, 6 hours, 18, up to 3 days, and in certain cases, even longer. So that's why, constantly disinfecting areas of high human traffic. If you go out to your grocery store, et cetera, you'll see that they're, wiping everything down. I went out for Mother's Day to get some stuff, and they are trying to keep fomites. This is, clean. They're trying to disinfect everything where people are near. But now let's go back to the two people talking to each other. If they're both wearing masks, then the amount of large droplets reaching a surface is reduced. The amount of small droplets that are then aerosolized and come into contact with another person's face are reduced. Oh my God, there's a dog, and he's like my Bernie. Anyway, sorry. So the amount of droplets aerosolized, the amount of droplets that drop onto surfaces is reduced. It's minimized, right? It's not eliminated. These masks are not N95 that people are wearing to the grocery store. We don't want them to be buying N95. We want them to have just the basic covering over their face and nose. So if they are around a lot of people, these droplets are not getting inhaled. They're not falling on their mouth when they're talking to other people, etc. And then long-range airborne is something that we're investigating, where you're in an air-conditioned environment, which is going to happen more and more as the spring and summer wears on or comes on, I should say. And air conditioners are known for recirculating air in closed spaces, and it could potentially create a scenario where I'm sitting here with my wife, we're eating, and take your mask off to eat. I'm trying to create a scenario for you, and people over on the other side of the establishment, someone coughs, it gets intake, into the intake of the air conditioning system, runs along a vent, and then drops out of another vent, and it's near us. We'll get to why we can eliminate that kind of scenario when we get to testing and the quarantining and all that stuff. But this is the kind of thing to think about. This doesn't get transmitted by touching another person. This doesn't get transmitted by, if it is, it's a handshake and then rubbing of the nose. The viral particle has to be brought to the area of entry, right? The mode of transmission is I shake a person's hand. Well, I'm sorry. Person has coughed into their hand. Person is positive for the virus. I shake that person's hand. I'm still not going to get sick. It's on my hand until I really just kind of like mess with my eyes, and I've got allergies this season, and I'm messing with my nose, and then the virus has route to my nasal and oral passages. Any questions? Okay, I have a question from Heather. Racine, Wisconsin, where I live, is listed as a hotspot. We're also listed as a hotspot here, where Jean and John and I live. It's the 8th fastest growing case rate in the nation. Same day I learned this, I have to go back to work at the front desk in a plastic surgery department in a hospital on the 25th. I'm afraid, terrified that I barely have gone anywhere in public in 2 months. Am I being irrational? Also, husband has an eye appointment tomorrow. Is it freaking me out? Oh, it is freaking me out. Is it irrational? Okay, so this conversation I have almost daily. I want people to be careful, but I don't want them to be fearful. I also don't want people avoiding healthcare scenarios that are necessary. The dentist, eye appointments, obviously if you're going in for Botox, and you have to go to a high traffic area, maybe reschedule that. But electives are coming online, and we've learned how to create environments that are safer for people to avail of healthcare. So obviously mask up, be very cautious about what you touch. Make sure that that you're going from your green environment, your home, to a red environment. And in that process, when you come back, you want to eliminate contamination from your hands. You don't want to bring your mask into a place where it could potentially create fomite spread in your home. Just be careful. Just think about the fact that you don't know how many people are in and out of there. You don't know how many people are recovering and we're sick, and they're just getting tested now. All of these questions need to be in your mind, and you're going from a green to a red to a green environment. do the needful, and don't be terrified. Just be vigilant, be cautious. As far as you working, starting the 25th, there's a whole set of best practices that I'm assembling for a number of my friends in the hotel industry and the small business, industries that are reopening all over the country, Utah, California. They've asked me to, look at the WHO recommendations. We don't have recommendations yet from our federal government. Each state is assembling their own, but we'd like to have somewhat of a unified approach to protocol. So how to manage a mask for 8 hours, how to manage your own, hand washing for 8 hours. I'll definitely be covering that stuff. Not necessarily today, but I just want you to know that, I will be putting that information out. And it is important, because once these things start to open back up, it's not just about taking care of yourself and your family at home. It's also about using the best practices and advice so that you feel confident and safe going into work and coming back home. Yes. I have a new friend that joined. Her name is Amanda Emerson. And Amanda has just an outstanding way of explaining things. I've noticed. Just met her, I think, today, or yesterday. And so I'm going to ask for her help more and more as we go forward. So we will. Do we have a question or just a comment?
Oh, no, I just wanted to, if you were going to ask me a question.
Oh, no. Do you have anything to say, Amanda? That would be great.
Oh, in particular to...
So the work environments and anything like that. I'm going to probably ask your help.
Oh, sure. That would be great.
Okay. Yeah, we'll put something together for people, because there's a lot of fear about going back to work. And I think a lot of people here in Pennsylvania, at least I've seen, that have worked through the lockdown. They've come up with their own solutions, and hopefully they've worked well enough to protect them. But they're not based on best practices that are just going to keep you comfortable and safe day after day for the next 6 weeks until we really, find out whether this is under control, and create safer ways of doing business with this.
The topic that came up earlier today about the people who are actually afraid to wash their hands because they're afraid that that's going to reduce their immune barriers is really...
Yeah.
That's something that we really need to maybe clarify for the public.
Without a doubt, because the first 2 weeks...
That's really dangerous.
Yes, without a doubt, because even the first 2 weeks that my colleagues in Philly and New York, they were, washing like constantly, very, and dried hands and callus, just you could see the skin coming off. I'm like, guys, even people who are around that all the time, they suffer without the knowledge of best practices and taking care of their skin. So we should definitely cover that. I have a question earlier. I think we covered it when it came to the R0. I think, Amanda, you covered it. Sandra, you asked a question. Sandra, do you have any questions that you verbally want to ask?
No, I just typed it in there. I was just asking about the R0 of chickenpox, and I joined a half hour late, so forgive me. You may have already covered it.
Oh, no problem at all. Yeah, we started off with just the infectious disease triangle and breaking the circle of infection and what R0 means and what R effective is. So yeah, various infectious agents have their own innate R0. It just is a measure of their infectivity and transmissibility. Chickenpox, as Amanda said, is about a 5 or 6. Is that correct?
I think it was higher than that. It was 10 to 12. It was smallpox that was 5 to 6, I think.
Oh, it's 10 to 12. Okay.
Yeah.
It's really infectious. Okay.
Yeah.
So that brings up the question of when I was younger, I came from a very big family. And when I was younger, when one of us got the chickenpox, what my family, an extended family did was it sounds crazy, but we had what's called chickenpox parties, where they got everyone who hasn't already had it closer together and kind of leave everyone else away from them, and it was used to build immunity. And of course we'd get the chicken pox, but then we would be immune to it later. So I didn't know if there was anything like that, or is it not safe to do anything like that for something like this? And if not, why not?
Okay, so I don't know the mortality rate of chickenpox. I to be honest, I don't know the mortality rate. I know the morbidity rate is extremely low with chickenpox. It is a childhood disease. There was a question regarding whether, varicella zoster causes any problems afterwards, and we know that it can reemerge, it can stay and remain dormant along the nerve cells in your body for decades and cause shingles later. All of that is, the basics of it, but it's not a deadly disease, right? And so one of the other many reasons why we don't create vaccines against n number of diseases, the vaccines that we have focused on creating against the diseases are diseases that cause very, very significant morbidity, which means after that you get the disease and you recover, you're scarred for life, like polio or smallpox or measles. And also they're the ones that kill. So with a unknown, let's call it for now, mortality rate, a case fatality rate of anywhere between 1.5 and 13%. This is not a disease to be experimenting with in terms of the building of immunity. We covered a little bit about herd immunity and why it's not wise, why the Sweden experiment is not a sustainable one between now and the time where we do have an effective vaccine. They will lose, compared to their neighbors Finland and Norway, they will lose 10 times the number of people. They've already lost 10 times, and they will continue to lose 10 times the number of people to death, okay, than those that have adopted a much more conservative approach to managing the disease. So try to answer your question. It's not wise for us to try and either at the family level or the community level just let it spread and then have, cross our fingers that we're right. 80% of the people will recover without much problem, which is, I think, not true. Because I'm talking to patients that are 35 years old and hikers and healthy and suffered a 5-week course of disease and have recovered and are negative, and are now suffering with low oxygenation. Home pulse ox is in between 80 and 90. They're racing hearts. There is not a definitive recovery for everyone that we normally think will get through this and they'll be fine. Okay. This has killed marathon runners. This has killed, mountain climbers. This has killed people as young as 18 years old. We don't know enough about this to just say, you know what, let it ride and let's see what happens.
Thank you.
Yep.
Yeah, that's what bothered me about that hearing today. Rand Paul was going on about, the Sweden model, and yeah, we should be doing that. And it's like, no.
Well, look, I mean, everything in life, everything's a histogram. In science, everything's a histogram. On one end, you're going to have the extremely conservative approach like New Zealand and Taiwan. Lock everything down, lock everyone away, minimize the number of deaths to single digits. And that has a cost, but it also has a benefit, okay? We don't know how many thousands of lives were saved by doing that. And we also don't know how many lives were not ruined with the sequelae of having been sick and not being able to get back to work. Okay, because there's going to be tens of thousands. We've got 1.3 million cases in this country. There's going to be hundreds of thousands of people who have been sick for as short as 2 weeks and as long as 5 weeks or longer. And then they're going to struggle to try and get back into the workforce because they are carrying scarred lungs or, scarred kidneys or something. And they're going to require hundreds of thousands of dollars more of healthcare throughout the rest of their lives. So there's a financial burden, there's an economic burden, there's a productivity burden to just letting the disease run its course. Okay, it's not just about what it costs right now, it's about the next decade of dealing with these people that are recovering versus the 1,300 that are going to need care in New Zealand that got sick and recovered. We've got 1.3 million. Okay, so we have to think broader than just that. I know small business is hurting, and you've got advocates, like I said, on the other end, on the the very not conservative. What would you call it? Let's say just it's a more a business focused, economically focused approach of there's also huge detriment in keeping people home for months and to the economy, and we need to also look at that factor. And maybe addictions will go up, and there'll be suicides, and alcoholism will increase. And yeah, there's no doubt there's evidence for that as well. There's even evidence that that women are being abused more. This is horrific. It's all horrific. And they're advocating let's get back to normal as soon as possible. And I saw a piece by I think Smirkanish, and he presented the data beautifully, and he's right. He's right. There's a cost to that as well. So everything's a histogram, and we got to find a balance between opening up and just free, doing it without caution, and then doing it so cautiously that this actually deepens the crisis over for a group of people that are really hurting already. So that's my take on it. And I don't want to stray too far into socioeconomics. So this is really about the biomedical stuff. If you want my opinion on socioeconomics, you can go to my page, and it's not very pretty. But anyway, more questions. Where are we, John? Okay, great. So this is my favorite stuff. I don't know if you guys like it. You're going to hear a lot of stuff about mutations and strains, and the new paper came out, and there's 30 new strains of it, and there's one dominant one, and it's a real killer. Again, this is a little bit of commentary on science reporting and not necessarily the media in general. The science reporting that we're seeing right now is crap. There's not a lot of good because not a lot of time to get it out there. So they digest it quickly and then they regurgitate it quickly, and it's not good. So let's go over what's a mutation, what's a strain. So we've got a virus. It's up here in the upper right-hand corner of the screen. That's what it looks like. A mutant is the same species, but it is distinctive in one specific way. That could be a mutant version of the red protein that you see there. That red protein is the spike protein. That could be a mutant version of that. There could be a mutant version of the yellow protein that you see there. That's the envelope protein. Then there's a protein inside of the virus called RNA-dependent RNA polymerase that makes copies of it. And all of these are very complex proteins, and they can mutate. And when they mutate, you get a mutant. All right? So that's all that is. Now, a strain, it's the same species, but it is genetically distinctive, which means that it acts differently and it looks different. Okay, so it can actually physically look different from another one when you look at it under a microscope. It can act differently inside of a cell when you put two strains together in a cell culture and you watch them, do their thing. They do it. They infect differently. That's a strain. Okay, some strains are more aggressive. Some strains are more latent, which means some strains can sit in your throat for 2 weeks and do nothing to you. Some strains will put you in the ICU in 4 days. Okay, So this is what a strain is. And now a variant. A variant, oddly enough, I had to go back to the books and figure this one out. A variant is the same species, right? So it's still SARS-CoV-2, but it is behaviorally distinctive, which means that it came from somewhere where it's not. It came from somewhere where it's native, all right, and it has a variant which has made it infect what we call anomalously. So it came from the bat, or it came from the pangolin, or it came from pig, swine flu, came from chickens and ducks, the avian flu. So it's a variant, right? It's genetically the same species, but it's a variant it's a variant because of both mutation and being of a specific strain that causes it to infect anomalously, all right? So there's 2 papers out this last week. One is from Los Alamos Labs, and it says that there's a pipeline of spike mutations that might make it hard to make a vaccine. There's going to be a lot of preprint publications that the science writers at the New York Times and at the wherever are going to grab and say, oh, this is interesting, let's write about this, because they need to fill columns. And it is interesting, and they will be right once in a while, and they will be wrong once in a while, okay? Not only the science writer, but the paper itself. Their conclusions may not be found to be correct over time. So just, take everything with a grain of salt right now, even if you're reading it from reliable sources. Okay. And then Utrecht University found, and also IIS in Israel have found blocking antibodies. So they're able to create antibodies that are what we call recombinant, and they've been engineered to do a very specific thing. And they have been able to create antibodies that they're now testing in vivo, which means in mice, to see that if you infect these mice with this virus, can it block it from infection and causing the infection or attaching to the similar types of respiratory endothelial cells. So, and they have positively found neutralizing antibodies. So that's awesome. I mean, that, again, John and I have been stressing this for weeks. This would not have been possible without HIV research. What you see is those red proteins are also present on HIV. And so there were some early papers talking about, well, it has an HIV-like infection quality. Well, no, but it has a similar mechanism that it has a spike. It has a surface coat protein in the case of HIV that helps it attach to a specific type of cell in your body, and that attachment causes the infection. Well, causes the proceeding of the infection. Okay, so here's the bad news, and this is what I think I wanted to stress to Sandra as well. The longer you allow the infections to continue in the general public, time and transmission are the primary factor for the emergence of mutations. The longer you allow it to just go from person to person, the more opportunity you give it to mutate. The longer these mutations accumulate, the faster new strains are able to generate themselves. And worst news of all is the longer that's allowed to happen, like what had happened in the wet markets in China, or in the chicken and duck farms, or in the pig farms, you allow an infection to run rampant without testing these animals, whether they're carriers, it goes from mutation to strain to variant, and it's ready to jump to a new species. Okay, next. So we don't want that. We don't want more. We don't want, we've got 8 strains floating around the world right now. We don't want any more. And so that's why we need to crush this thing as fast as possible. All right, now fun stuff. Unfortunately, my buddy Mike Null, who usually joins us, is not here. But he asked me last week about a couple of things that were in the news. So it was found that people with the BCG vaccine, I think I've got one. Yeah. So those of us who were inoculated to protect against tuberculosis with BCG, was a skin vaccination, have long-term studies have found that we have lower rates of respiratory infections, lower rates of illness, and it's not just because, and that has to do with those of us who got the BCG vaccination versus those of us who didn't. We had lower rates of respiratory infection and illness than those who did not. Weird. We don't know why. We have a theory though. And we're also finding in France and Italy and Spain that those with BCG vaccinations are less susceptible to COVID. And we have a theory. The theory is called molecular mimicry. If you have ever seen a, what is it called? A stick insect, right? It looks like a stick, right? It's called mimicry and biological mimicry. It camouflages itself to look like a leaf, an insect that looks like a stick or a leaf. Well, that's to camouflage, protect itself, or create a diversion so that it can be better predator or whatever. We have at that, that's at the level of phenotype. At the level of molecular biology, we have molecular mimicry. One of the ways tuberculosis protects itself is with creating a huge, thick peptidoglycan wall around it, okay? It's so thick that even if you put it in a solution full of antibiotic, the antibiotic has trouble seeping through that outer wall to actually get inside the bacteria and do what it needs to do. That's why we have to use extremely high concentrations of any antibiotic to treat tuberculosis, and we have to use it for a long period of time. I'm talking 6-8 months, okay? So one of the things on the outside of the molecule of the bacteria is a mechanism to protect itself from the immune system. It molecularly looks like, let's try to go back to my analogy. So you got this wall. Instead of looking like a bacteria or giving indication of its true nature, it mimics other viruses and other proteins that other infectious agents use. So it kind of pretends to be something that it's not. The immune system comes and looks at tuberculosis and says, wait, this looks like a virus. It goes and tells B cells that it's a virus, but it's actually tuberculosis. So what's happening now with those of us who have the BCG vaccine is that early on when we got it, the ground up tuberculosis, attenuated, whatever, those bits and pieces, they look like so many different other infectious agents that our body has been trained to actually tackle the molecular mimicry. Okay, so that's one. Smoking. Terry, buddy, you know what I'm going to say, right? The cruddy lungs full of crap from smoking for decades. For some reason, you got lucky. It's a COVID protector. That's the biophysics of it. It's not the nicotine, or at least we don't know whether it's the nicotine, but it's probably not the nicotine. It's probably just the fact that there's so much debris in the lungs of long-term chronic smokers that it's hiding the receptors necessary for the virus to grab a hold. Okay, that's one. Number two is that the underreporting of smokers' disease is a result of also smokers being notoriously bad about going and seeing doctors because they don't like being told to stop smoking every time they go.
I have no idea what you're talking about.
So there we go. That's another reason. We don't know. They probably get sick at home and recover, and they don't go through the full horrible course of the disease because the virus can't get at their get a grip on their lungs. So there's one thing that we learned. Llamas. So a couple of years ago, when they were doing research on MERS, and as well, they looked at camels as a vector for the virus, the host being an intermediary host. So they also used llamas to test, and for whatever inexplicable reason, they found that llamas are quickly able to develop neutralizing antibodies against SARS-CoV-2, so COVID-19. when it's given to llamas, they create these very high binding neutralizing antibodies. But is it protective? I mean, is it? We don't. I'm not a veterinarian, so I'm not going to even say what's going on with that. All we know is that medically, it's a very interesting finding. We do not know whether or not we can extract the antibody, purify it, and use it as some sort of therapy in humans. Normally, to do something like that would take a very, very long time. And the reason you want to be very cautious about introducing any proteins that come from another animal into the human is because it can elicit a horrific anaphylactic reaction, or basically, create more problems than it could solve. Okay. Any possibility that pneumovax is a protective factor? No. Again, vaccines are very specific to the type of organism that they are protecting you from. So not likely. And again, the BCG vaccine is kind of one of those oddities that, because of the way tuberculosis looks or its morphology, that, and then molecular mimicry is what is conferring, kind of a little bit more resistance to other diseases once we have that. But pneumovax, we don't really know whether it would be useful, but vaccine theory would say that it wouldn't be very useful. Okay. Good question. I'm getting to that. Supplements later. All right. So protection. So what is quercetin, or whatever, how you pronounce it? All it is it's a purified form of a flavonoid. And a flavonoid is a molecule that's commonly found in fruits and vegetables. And I have a slide at the end of this deck that will go over that. But yeah, someone said that elderberry and other flavonoids are useful and protective in this disease, and in general in pulmonary infections. And so you saw it fly off the shelves along with zinc. You can't get zinc now. Yeah, just eat broccoli, for Christ's sake. I mean, I don't know what to tell you. Flavonoids are everywhere. I have a whole list of them at the end of this slide deck that I'll show you. Melatonin is a well-known anti-inflammatory. It's a well-known immune modulator. It's a part of the natural circadian rhythm that your body secretes, at the end of the day, to bring your heart rate down, to bring your muscle tension down, and to help you relax and fall asleep. So do I recommend taking melatonin? No. Melatonin at night to help you sleep if you have anxiety? Yes. Do I recommend spending time looking for bottled quercetin? No. But do I recommend that you do take vitamin C and vitamin D and a multivitamin that has mineral supplementation such as zinc, manganese, magnesium? Yes, and I'll get to that on another slide. Absolutely. It does not harm you. Again, please know that there are two types of vitamins. One is water soluble, one is fat soluble. Or one class is water soluble and one is fat. You can take huge amounts of the water soluble. Your body will look at it and say, okay, I'm going to use what I've got. I don't need this. And then it goes out in your urine. If you try to do that with the fat soluble ones, the body says, how much do I have? I'm going to store it in my liver. I'm going to store it in fat cells, and I'm going to store it in case I need it later. But if you go overboard with it, you can overload your liver and it can become toxic. In the case of vitamin A, vitamin E, those are, you have to be very cautious with overdosing on those. It takes a while and it's a lot. You have to take a lot, but please just don't. Okay, take the normal USDA recommended dose. Over-the-counter vitamin supplementation is fine. Just don't overdo it. Okay, next. All right. Morbidity and mortality. Morbidity, this is very, very important. 80% of the people that get this disease are going to recover and be fine. 95% of the people that get this disease are going to recover. But we don't know what percentage of those groups are going to recover and have long-term problems, long-term medical requirements for treating their pulmonary fibrosis, cardiomyopathy, chronic kidney disease, hepatic failure, whatever. This is not a disease to be messed with, because it's not just infecting your lungs. It's not just causing pneumonia. We've just learned that in the last couple of weeks. It is a disease. It's an antiviral etiology. It causes immune modulatory problems. It causes microangiopathy and clotting problems, and those can affect anything and everything. People have come out of this recovered. They can't think straight. They feel foggy. They can't concentrate. They can't walk up a flight of stairs 4 weeks after recovering from it. This is not good. And then there's some people that, again, like I said, they got sick, they had a cough for a week, and it went away. Okay, so we don't fully understand this disease. We want to know, and we'll get to here, what percentage of people and why. What percentage of people suffer the mild course of disease and why? Is it because of the strain they had? Is it because of the concentration or the type of ACE molecule that they express genetically? Whatever, we need to figure that out. And it's gonna take a little bit of time. It's not something we can do in days to weeks. It's something that we need some time. All right, so morbidity is dimension of health that we assign at the end of the course of disease, that says these are the long-term chronic sequelae, conditions or diseases that are a result of having this infection, and then we can use these to follow the patient and evaluate their health status. And in the population, we can follow the prevalence of the health problems that emerge. So what percentage of people end up with lung fibrosis? What percentage of people end up with chronic kidney disease or with cardiomyopathy? Those are things that we need to figure out. Mortality, my favorite saying, did you die? And unfortunately, not to make light of it, we've lost over 1,000 healthcare workers, and we've lost over 80,000 Americans. And I've lost some friends and some family, not direct family, but and colleagues. And so it has a cost. If you haven't seen it, know that it's there. It's got a cost. Next.
Sanjay.
Yeah. Yeah, please go ahead.
It's Joanne. I'm with Gina.
Yes, Joanne, go ahead.
We lost you for a little bit, so if someone already did ask this question, I apologize. But this afternoon when I came home and I was listening to the local news, and they're saying how many people were cured and left the hospital. How are these people being treated? Like, what are they being given in the hospitals to enable them to be able to walk out?
So that's a great question. I want to answer that as plainly as possible. Okay, 4 to 6 weeks ago, they were given supportive therapy. What we mean by supportive therapy was just to make them comfortable. We needed to control their fever. We needed to make sure that they're hydrated. Just the basics. Make sure that they don't enter a phase where their oxygenation is so low that we would need to supplement beyond just nasal cannula or oxygen face mask, but actually intubate them and put them on a ventilator. That was the strategy 4 to 6 weeks ago. Emerging in the last couple of weeks is more of pharmaceutical intervention. Like, okay, make sure that they don't enter a phase called cytokine storm. So we've been using we've been using, you know, the basics like prednisone to get their immune system to calm down and not, you know, to create a situation where it's attacking the lungs and all the other tissues because it's been activated. So that's one. So, you know, just the very basic tools of acute care medicine. And then also we found that with clotting, you know, severe clotting in some patients emerged, and we started to use low molecular weight heparin, again, an old standby, to make sure that we don't get the clotting that we saw in those initial patients that caused them to, some of them are losing digits because their fingers and toes turn black because of the little vessels in their extremities get clotted. And then most recently, you know, I don't think a lot of patients have gotten this, but antiviral medication like remdesivir and others that are being tested. So we're getting to a point where we have a protocol that's being called for by Johns Hopkins, by Mount Sinai, by UCSF, Mayo, and others that are saying, okay, look, this is what we've learned in the first 4 weeks of treating these patients. We've assembled all the evidence, and this is how we got them out of the hospital. We controlled their fever, we controlled their airway and their breathing and their oxygenation. We let the worst of the virus do its thing with, you know, the lungs and whatever, and then we kept them stable until everything subsided. The course of the disease went, you know, it took its normal course. And for 80% of the people that you know, that had to get care in the hospital, let's hold on. 80% of the people don't even have to go to the hospital. Okay. And then there's a large group of people that go to the hospital and they've gotten discharged. Okay. So let's not forget that too. There's quite a few people, maybe 60, 70, 80%, whose length of stay and course of disease in the hospital was 4, 8, 10, 12 days. But then there's that small percentage that do very poorly, end up in the ICU, end up on a ventilator, and the ventilator averages are absurd. As you know, I saw on the low end, 10 days on a ventilator, on the high end, 31.
Wow.
Okay, length of stay between 64 and 70 days. We've never seen stuff like this before. Okay. And then, of course, like I said, majority of everything's a histogram. Majority of the people are just going to get the kind of care they need that they wouldn't get at home, right? Hydration, fever management, all that stuff. And then we can discharge them. They can go home and hopefully everything's good. But then there's that group that go on to die, right? And have a horrible course of disease. And then there's these that maybe, I don't know, we don't know, what, 10, 20, 15% that are getting clotting, you know, kidney issues, neurological issues, you know, peripheral vascular damage, cardiac damage, pulmonary fibrosis, pericarditis. So.
Well, are these problems just aggravated? I can't think of a better word. Because
did they have them beforehand?
Or did they already had them?
No. That's a different group of people altogether. In fact, I would include those people that were really of poor health as the ones that end up in the ICU. I'm talking about healthy people, marathon runners.
Okay.
There's some group, you know, 15, 20, I don't know yet, that fare poorly and leave the hospital with sequelae. Okay, and the word we use is sequelae is stuff that follows you, stuff that happens as a result of the disease. Comorbidity, they're morbidities that came with the disease.
Okay, thank you.
Got it?
Yep.
Now, Doc, you were just talking about, you know, like the drug therapy. Now, what's the, I don't know how to say it properly, but, you know, are all the hospitals on the same page? Like for us here in our area, am I going to get the same treatment if I go to General than if I go to Geisinger?
No, you're not. In fact, they're not using the same PPE methods and protocols. There's no national standard at all. There's no coordination federally. The CDC hasn't issued, FDA hasn't issued guidance on how these patients are to be treated. So I'm hoping the next maybe month we will have standardized this, but what am I going to say? This hit us like a ton of bricks. It hit the healthcare community, broadsided it to the point where you had some hospitals that were sitting around and doing nothing, and at other hospitals, they ran out of protective equipment in days, right? Like it just hit so weirdly. It just hit hot spots, and then you had those community hospitals that are standing around, doing nothing. There's no COVID patients, but they had to shut down, and so all of their electives went out the window. No one was being admitted, and then you had Elmhurst and Sinai and all of them, with ambulances down the street and around 4 blocks trying to get patients into the hospital. So I can't blame anyone, but I can say that no, we don't have a national standard for treatment. But I'm getting to why John and I are doing this, and why I'd like everybody who watches this to be armed with some information, because I will give you information that will come out in the news next week or the week after, because I and other colleagues of mine are reading all the preprint literature. We're talking to each other. We're sharing patient information, anonymous patient information and experiences with each other, so that we can say, hey guys, this is the 19th patient we've seen with this symptomatology, and I heard the guys at Sinai did these 3 things, and similar patients did really well, right? It's all anecdotal, but we're gathering the evidence. So, why are hospitals empty? Because you keep hearing in the news, hospitals are empty, and we covered this earlier. The electives were canceled, okay? Either staff were rerouted to take on COVID patients and therefore weren't available, or the hospitals just shut down parts of their operations because they didn't feel it was safe enough for those patients to be in the same environment as COVID patients. So why are they getting laid off? Well, they're getting laid off and furloughed because hospitals have taken a huge financial hit. Elective procedures and other things are where hospitals make their money. They're 70% vacancies and things like that. There was an initial huge media outcry that came on behalf, through the media on behalf of healthcare workers, that we might run short of ventilators. And yes, all of that would have been true. All of the modeling would have been true if we had let this just go. If we had let the R0 go to whatever it was going to be, 2 or 3, no non-pharmaceutical interventions, no social distancing, no lockdown, no, if we had just let it go, we would have been overrun in 2 to 3 weeks. So this is where we are. We've got 2,100 patients right now on, hospitalized and on ventilators. The other form of oxygenation is extracorporeal membrane oxygenation, otherwise known as ECMO. It's used in dialysis patients, etc. And so it's a rare form in which we have to get oxygen into the bloodstream. So you can see, we've got 10 adult ICU beds available. We've got over about 90 surgical beds, etc. Apparently, we don't have any pediatric ICU beds available. I don't know what that means. I don't know if these numbers are correct or accurate. But we're in a hotspot, right? John, Jean, and I are in a hotspot. And it's one of the reasons we have guidance from the state that we're not going to go to the next stage until what, June 4th? So there we go.
June 4th is correct. And Dave Pedri, the county administrator, was actually at their meeting tonight trying to get our county open before June 4th, trying to follow the reins of Schuylkill County and those other counties that are trying to open before they should.
Yeah, we covered this, right? You could do that, but you're risking losing all the progress that we've made. And people will not understand. They'll be like, what progress? You know, beds are empty. 70% of the ventilators are available. That's the progress. That's the progress. Okay, not getting overrun and having people, in tents outside the hospitals. That's what we avoided. I'm not being hyperbolic either. Okay, because we saw it in Italy. We saw it in Spain. We saw the beginnings of it in UK. Okay, before they got their stuff together. But Italy was totally overrun, especially in the north. And so that's the progress. Now, do we want to risk that? It's not a question of do we want to risk that. We will risk that. And I'm not saying that with 100% certainty that the modeling is correct and we will be overrun and, people will be, dying in the halls of hospitals if we all go back to work tomorrow. I'm not saying that. I'm saying that caution is merited. Okay. Reports of heart attacks are down, strokes are down, trauma is down, vehicle accidents. Well, obviously, there's no one out there, doing their normal routine and business that would put themselves at higher risk for stroke, heart attack, trauma, and vehicle accidents. So it's obviously just like saying that, gunshot wounds are down. Well, nobody's out getting in fights right now. So.
Take a quick 1 minute break to see a weekly message from Dr. Levine, and give us a second because that'll play into our next topic.
Thank you.
Now here are my daily reminders. Please wash your hands with soap and water for at least 20 seconds, or the time it takes to sing happy birthday twice. Use hand sanitizer if soap and water are not available. Cover any coughs or sneezes with your elbow, not with your hands, and try not to touch your face, especially at touching surfaces. Clean surfaces frequently. And if you are going out for life-sustaining activities, please wear a mask if you're going to come in contact with others. Practicing these everyday prevention measures can help slow the spread of the dangerous virus, COVID-19.
Okay, so we began to cover this earlier, and I'll just recap it quickly. Hand washing and face masks, when and how. So, being mindful of contamination. Again, Amanda, if you're still with me, the question of how often should I be washing my hands? Well, if you're at home, then wash them normally, right? As they get dirty. If you are going out of the house and coming home, then you have to be more mindful that your hands are contaminated and they need a good wash. If you're at work, then you need to be washing them again, as and when necessary, but not on a regular schedule, because what you will do with a regular schedule and continuously look at your watch and say, oh, it's been 15 minutes, I gotta go wash, or it's been 30 minutes, I gotta go wash, is that you will begin to wear away the protective layers of oils, protective natural oils and things like that, and you may start to do more damage to your skin than it's worth to go through that. Is overwashing a danger? It is a danger if you're doing it wrong, right? Like I just mentioned, every 10 minutes. Now, if you're a healthcare worker, we have other protocols, and I don't need to go over that. If you are a service worker, then John and I will cover best practices for you next week. That's definitely probably the number one topic. Getting back to work and dealing with learning best practices and learning the habits that are going to make you safer and more comfortable at work. Okay. If you're overwashing, you're doing it wrong. If you feel that your mask is preventing airflow, you're doing it wrong. You either have an ill-fitting mask or the wrong density of material, And then you should definitely look at something that is more suited to the size of your face or the activities in which you are engaged, both mostly at work. But a basic surgical mask and a neck gaiter, like we showed you last week, is going to be more than enough for an hour or two outing to do shopping, and it's going to be it's going to minimize the amount of exposure that you have to others that may have pose some risk, and it will also minimize the amount of expectorant. And if you don't know your testing status, or you may be unknowingly a symptomatic carrier. Okay, next. Probably will publish this right on the page, because if you want to know what vitamin D does, and vitamin C, these are what we call cofactors in biochemistry. They are necessary in certain enzymatic reactions. Vitamin D is most important in bone density and regulation of certain immune functions, calcium metabolism, etc. So vitamin D, very important. We get a lot of it naturally as a result of being in sunlight. It's a complex reaction that various forms of vitamin D are converted in our skin. You can get vitamin D supplemented in milk. It's all related to a neurohormonal axis related to calcium metabolism. And calcium is everywhere in the human body. So it's in your muscles, it's in your bones, nerve cells, everywhere. And regulating the appropriate levels of calcium and where they're stored and how they're utilized is one of the main roles of vitamin D, and it's also involved in certain immune mechanisms. Now, if you want to learn about those immune mechanisms, it will take a few $100,000 and I think 3 or 4 years. So anyway, vitamin C also important to supplement. It's very important in what we call barrier integrity, the production of collagen, which is everywhere in your nails, your skin, but also the maintenance of iron metabolism in your bloodstream and maintaining the health of your red blood cells. Okay, minerals such as iron, obviously necessary for oxygenation and your RBCs and all this other stuff. And then, of course, we have zinc. Zinc is absorbed in the gut, and it is used in a lot of proteins, structural and enzymatic. And so a good amount of zinc in your diet is great for your immune system, as well as general protein metabolic health. Over here, flavonoids. So you've heard elderberry, quercetin. I hope I'm pronouncing that right. And so these are all the flavonoids that you get from various sources. So parsley, tangerine and oranges, and broccoli and apple skin and strawberries, and even my favorite, black tea, Indian chai. These are all sources. So if you don't eat any of these things ever, you will have certain deficiencies. If you eat these things once in a while, you have enough. And if you want to supplement with extra, then just eat a little extra of what you find tasty, like blueberries and raspberries and cherries and broccoli and apples and strawberries, which I like. So again, there's no need to go and find a bottle of quercetin when you can have, you can just normally and naturally elevate your intake of all of these things. Got it? All right. Sanjay's plan to get America back on the road. All right. We're living in a world of risk right now, and we need to get to a world of safety. So that doesn't mean we're going to stamp out every virus. That doesn't mean that we won't face a virus like this in the future, but there are certain things that we have to do to get there. So, all right. So first thing we need to do is assess prevalence. That means How much of the virus is where? We need to have free testing on demand, okay? Right now, to get a antibody test to figure out whether you had the virus or not is upwards of $120. It's really only reliably available from one lab, Quest. There's others, but they're not reliable. We need to be able to provide serial detection and antibody testing also on demand. That means if you're positive, if you're negative today, 2 weeks from now, as a result of where you work or your risk level, you should be able to get tested again. Just because you test negative doesn't mean that you are, the risk is eliminated. It just means that you've not been exposed yet. When you do get exposed, then rigorous contact tracing is required. Now, if it's not going to be offered at the federal level, we're going to have to do it at the community level. That means either at the county, township, or even the state would be great, where we gather data and find out. We don't have to share names. We don't have to share our personal information. We don't even have to share how much information we normally share on Facebook or Instagram. We just have to share whether we've been tested, and if we are tested positive, certain circumstances that may have led to us testing positive at the community level. And then I don't know if we can rely on strict quarantine, self-quarantine of the positives, but ultimately we're going to have to move to a model that only quarantines positive cases. All of us sitting home alone is not going to make this thing go away. We've got to reinvigorate everything in our lives to be truly, healthy and back to normal, all of us. But part of the process is getting tested, having the availability of tests, and then quarantining those that test positive, and then obviously figuring out where they got it or how they got it. Healthcare access. Everybody who tests positive for COVID and falls sick should be allowed to go to the hospital if needed, or secure at-home medication for free. I don't know how we're going to do that, but it's a must. This is a national challenge. This is not something that we leave out or leave behind anyone, because if we do, guess what's going to happen? Everyone else is going to continue to suffer. So either we take care of everybody or we're all going to suffer. If you get sick and you recover, a certain period of convalescence, I would say about 6 weeks, is necessary as a national mandate for you to receive paid convalescence. That means please don't go to work, and please, even if you've recovered, know that you may be shedding live virus for up to 21 days. And we have evidence of that, and therefore you need to stay home and away from other people even after you get better. Data and analytics, which is my world. Obviously, people have to be able to submit anonymized data. We need at the population health level to assess it and then make recommendations, on a daily basis on granular data. We need to be able to point to a neighborhood and say, look, you've got 3 positive cases and you've got 1 kid in the neighborhood next to you that's suffering Kawasaki-like syndrome. Here's what we're going to do about it. Okay. You can't just wait for these things to show up on hospital doorsteps like we did the first 6 weeks. And then we have to figure out more about the genomics of this thing and halt any further inbound strains that may be non-native right now to the United States, strains that may be circulating that could eventually reinfect or cause a resurgence of COVID in the United States. We need to test international travel. So anyone and everyone crossing the border needs to be tested. And then track the strains that are arriving. Any questions?
I guess my only question is, how are we ever going to get the powers that be to get behind this?
Hey man, I just work here. You know, this is again, I can give you the best science, and that's it. That's all I can do. It's up to the rest. I mean, all of us together collectively should be writing to. I have a friend on Facebook here I've been communicating with, who's a data guy in Las Vegas and manages properties there. You know, he's writing to Congress people and yeah, that is Karen's job. Exactly. Collective action. Karen, you're on it. You're assigned. We'll get Amanda to help you. So that's really about it. You know, everybody's got a role in this. I know what my role is. And I will continue to do this. I've done this, did this for Ed Rendell when he was governor of Pennsylvania. I've worked on, you know, John knows, I worked with our local representative, Ed Pashinsky, on a healthcare reform task force. Put together recommendations that eventually went up the chain to the federal level that became part of Obamacare. So on the data and electronic record side of things and population health. So my voice is a science voice, at least here. This is it. This is how we fix this. This is how we go from facing a risk on every day we walk out the door or go to work. Unless we do these things, we will not get to safety. I mean, fight me if you want to. This is science. This is it. This is what I do. This is what I know. And unless we do this, we will not get to safety.
I can tell you that every state almost has some sort of grassroots collective action network, and I would recommend that people find theirs and get plugged into it. My nonprofit is part of People's Action, and it's a matter of collective action. You have to be with other people making the demands. It's much harder when you stand alone and make the demands. You have to get with other people and do it.
Yeah, you know, the person who's producing this video right now knows that better than anyone. He's been doing it for probably 2 decades. John is, I'm very proud to call myself John's friend, and I've watched him do amazing things with collective action.
Yes, 2 decades. I started when I was 5.
Yeah, right. Exactly.
We're going to go with that. I got a clippers, and I cut all the gray out so no one will know.
So I thought that I talked too much this time. I really felt I talked too much, but I hope I got enough information out to you. I'd really love to hear questions if anyone's still interested in asking. I'm here.
I guess I have a question.
Yes.
So it's the most annoying thing that I've seen on Facebook, all the people demanding haircuts.
Yes.
Is there any kind of data point where at this level in the community, when the percentage is this, that it's safer for that level of contact to go back to work? Has anyone determined that?
No, no, and that's a great question. But you know, the only thing that we've got as a proxy is, like the first slide, John, do you remember if you could bring up the first slide on Italy? Italy has had, I think, a 20-day decline continuously. That's just incredible, you know, considering what they were facing 20 days ago. If you see that in your community, then you're trending towards a place of greater safety, right? But then if you have an influx of people from outside your community constantly, again, the R effective is going to change dramatically as those places open up and service people outside your community. If your community is very much insular and that, you know, has dropped consecutively for 15, 25, 20 days, you're going to have a level of safety that's, you know, on a lower level of risk. I have Lauren asking, I have an antibody test scheduled at Quest this week, although I have no particular reason to suspect I had COVID. What is the potential effectiveness utility of the results? Do we know enough to make the results actionable at this time? Beautiful question. Beautiful question. Okay. So here's the answer. We know from previous studies that having a SARS infection and a MERS infection, which is essentially the same class of Baltimore 4 class of a virus, confers 2 to 3 years of protection. After that, the neutralizing antibody levels are seen to drop. Now, that's very different than getting your measles, mumps, and rubella or polio vax in youth, and then you have kind of this long sustained protection throughout your life. I can't really get into why this is different for different infectious agents, but what Mike Knoll, my classmate and friend, childhood friend who couldn't join us today, but has been joining us on a weekly basis, he also got tested. Last week he tested, and because he had suspicion, he had almost a 2-week-long cough and malaise and whatever, and in February. So he got tested this week, and it came back negative. Okay, so he lives in a ski town. He thought he may have come across clients that came from outside. He lives in Utah, and they came in, maybe they mixed and mingled, and he got sick. And travelers very early, pre-SARS testing, pre-SARS awareness, he got it, and he thought he recovered, but he's negative. Now, you tested. You're going to get tested and want to know what is the effectiveness. The effectiveness is for the next 2 years, if you are positive, which doesn't seem that you have a reason to suspect that you had it or should be positive. But if you were, like Mike, if you had that reason and he came back positive, there's a relative amount of protection. Now, when I say relative amount of protection, I mean almost equivalent to a vaccination. A vaccine is tested to provide protection 80 to 90% of the time that you're exposed to the infectious agent. If you recovered from SARS, I would say there's a greater than 90% chance that you will not suffer from SARS again in this season, and you probably are immune to it for the next minimum 2 years, if not longer. Then, again, I don't have evidence for this, but this is comparing it closely to viruses that are extremely similar, like MERS and SARS-1. That's the answer there. What I do not recommend is testing your new superpowers. So if you do, if you do test positive, don't go licking hospital doorknobs and going, hurrah. Okay, so, right? Okay. Yeah, I mean, Mike was hoping that he was positive, that he suffered that, flu-like symptom, and he wanted to, because he's going to be around all these people now. These clients are going to come back and have conferences. They're going to do the social distancing 6 feet apart, and he needs to train his staff to be able to service these, these small conferences. And he was hoping that he would have some immunity going into this next phase, but unfortunately no. Oh, you want to donate antibodies? That's awesome. Yeah, yeah. So convalescent serum. Oh, hey, John, did we not do the drugs? Does anyone want to know about that again?
Can you hear me?
Yeah.
Hello, I'm new on your page, and I love your page, of course. I've stolen many memes.
Okay, great.
So, question I have for people who take like a daily ARB or ACE2 blocker, certain medications like high blood pressure medications for hypertension. I've read through where they've done studies a while ago. It's not anything new, but as far as like ACE2 receptors and how this virus kind of takes hold and gets in. Do you have any information on any protection for people that take those daily medications, or any like something that could make it worse? Do you have any information on that?
Yeah, sure. So, okay, the latest information is that you need a surface that has the expression of two molecules. One is the ACE2 receptor and the TMPRSS2, which is adjacent to it, okay? So right now, we know that the adult versions of this are found in the in high density in the linings of your respiratory system. They're found in the mucosa of your oro and nasopharynx, and to a certain extent, they're found in the conjunctiva and of the ocular area. So, you know, the conjunctiva, as well as to a certain extent the area around the cornea. That is why it is so easy for this virus to fall on those surfaces and get a grip, so to speak. But you need both of those molecules for the virus to effectively go inside. An ACE inhibitor is the angiotensin converting enzyme inhibitor, okay? It doesn't necessarily work on the receptor physically. It works on the pathway, so it doesn't have a protective effect. Angiotensin receptor blockade, also ARBs, losartan and others, also don't have a protective effect discernibly, and that would need to be studied, but we understand the mechanism as to why they wouldn't be protective. So other medications that are that we're investigating. One was that, okay, if this causes clotting, maybe people who are on Coumadin for atrial fibrillation, or who are on aspirin for because they're on, you know, they have coronary artery disease or have stents or whatever, they would be protected. That's not true either. The reason that's not true is because the clotting cascade has different points at which different anticoagulants act, and where the virus has activity in disrupting the clotting cascade. Right now, we are understanding that only heparin, one of the blood thinners that we use in hospital settings, is the one that's truly protective. So low molecular weight heparin compared to unfractionated is the one that's being used in the John, if you could bring up the most recent deck that I saved on the, I think I've got that. But anyway, so there are some drugs that we recommend, but it's hard. I mean, it's not possible right now to recommend that you take anything, either prescribed or over the counter, that has enough evidence to recommend that it is protective. Okay? The trimodal therapy that is emerging right now is that if you get sick and end up in the hospital, my prediction again is we're going to half the mortality rate in the next few weeks by using this trimodal therapy that's emerging. One of the questions Gene asked is everybody doing this? The answer is no, unfortunately. University centers are experimenting with this. And those that, you know, those centers that are at the cutting edge of immunology and et cetera. So immunomodulators are there to prevent the body from kicking the immune system into overdrive and developing what's called cytokine storm, where the body does more damage to itself with its own immune system than it should. And it's a result of it's like, you know, somebody's running up the hill at you and you grab a 50 cal and start, you know, just spraying bullets. And that's what the immune system does when it sees COVID coming, to use a crude example. So certain monoclonal antibodies are now showing effectiveness because they are interleukin-6 receptor inhibitors. Not to get too technical, here are the top candidates: tocilizumab, siltuximab, and an old standby that you know as Pepcid, famotidine. These are immunomodulators that cause the body to suppress the cytokine storm, okay? So it keeps the body from doing damage to itself during the process of fighting the virus. The antivirals that are most promising right now, we have some good evidence on remdesivir. The federal government has mobilized, and FDA has made remdesivir available now. I think the initial 4,400 doses have been sent to New York hospitals because they still have a high patient load. We have found that a drug from the HIV arsenal, leronlimab, which is a CCR5 inhibitor, is highly effective in a case study of 35 patients. Highly effective, all of them recovered. COVID-19 patients. There's a drug outside of this country trialed by the Japanese, favipiravir, which I mentioned very early in these town halls. So these are the three candidates for the top most effective antivirals. And now, as I said, anticoagulants, as of last week, we were still thinking that maybe warfarin and aspirin might be useful, even not in a non-clinical, but even in a clinical setting. That's not the case. We figured out that low molecular weight heparin and nefomostat are the drugs that will most likely become candidates for anticoagulation to prevent the clotting and the infarcts that are associated with the disruption that COVID causes to vasculature. So this is where nefomostat acts, and you can see the two receptors I was talking about, ACE2 and TMPRSS2. Both of those are necessary for the SARS-CoV-2 to enter the human cell and cause infection. Nefomostat is an existing drug, and it has a strong inhibition of that particular molecule. You see TMP, and that will keep it from doing the second step and entering. Again, we need to test these, create a protocol, validate the protocol, and then in the next couple of weeks start trialing it all over the country. And if we start to see positive results, then this trimodal therapy will become pretty standard, hopefully, with further evidence gathering. Next. Leronlimab, again, from the fight against HIV, blocks the CCR5 receptor. Dr. Ram Yogendra, who does these town halls out of New York, he has done a couple, and they're on the page that John and I have established. There's a video library, and you can find an explanation of how this works and the trial that's been going on in New York. I think it's at Mount Sinai, and how effective this has been. So again, thank you to 20 years of HIV research and the last 10 years of HIV drug development. Here's the anticoagulant cascade. I'm sorry, the clotting cascade and the anticoagulants where they act. So low molecular weight heparin, mechanism of action is on factor X, factor 10 we call it. And this takes a semester to understand, so don't feel bad. This is what we're going to be using to deal with the clotting associated with COVID. Okay.
No, that's actually excellent. So basically, like I'm not in the medical field at all, but just paying close attention. So basically, just trying to kind of like playing with the virus, like playing it at its best game. So basically, inhibiting it from being able to take hold and enter into the system to cause infection is looking like a very good look as far as trying to get this thing under control before a vaccine.
Yes, correct. Exactly. I think that's the point I should have tried to make initially. Yes, we're getting a better grip on how this thing does damage, and then we're finding the spots at which we can trip it up, right? So is it at the attachment phase? Is it at the whatever we call it, those 4 steps that I showed you in the beginning? Is it attachment? Is it replication? Reassembly or propagation? At which step can we just kind of like cut it down at its knees and stop it from getting to the next step? Now, one thing we learned from HIV is there'll be a population that will stop with one drug, and then, within the histogram of the population inside that particular person's body, that population will stop, and then by this drug, we'll proceed to the next step, and another drug will have to be used to stop this group, and another drug will have to be used to stop that last group that escaped the first two drugs. You see what I mean? At different concentrations, we have to give all three to stop it from doing damage at various stages of its life cycle and at various places in the body.
Awesome. And I just want to say thank you to, doctors, researchers, nurses, everybody in the age of pandemic. This is so refreshing to get facts and science rocks, and that's how I sleep better at night, because I'm in Nashville, where we're also on a surge, and of course, in Tennessee they've decided to open up, and I'm not going to be out there. I'm not, but this helps me sleep at night, knowing that behind the scenes of an inept administration, there's real stuff being done to fight this. So thank you for this.
You're very welcome. Thank you for joining us. Thanks for the question. John, thanks so much for staying late and doing all the background work. I hope we got something out there on FB Live. But this will be, as John mentioned, this is recorded. It will be available later on that resource page, and it will also be available kind of cropped down and edited a little bit more tightly on YouTube. Thanks, everyone. Hi, guys.